Thank you, everybody. Like you said, my name is Kristina Murphy. I am chair, which is just another way of saying director of pharmacy at Christ Community Health Services in Memphis, Tennessee. We're in Memphis and Jackson, Tennessee. Just for my disclosure, I have no actual or potential conflicts of interest in relation to this program or presentation. Just a little history or a little info about CCHS. There's two CCHS I know, but we're CCHS Memphis. Our mission is to provide high quality health care to the underserved in a distinctly Christian manner. And we recognize that Jesus is the true healer of individuals, their communities, and the source of our ability to serve. So a little about Christ Community. We have 6 freestanding health centers in Memphis, 1 dental, 4 co-located dental. So we have 5 total dental centers, 5 pharmacy. We have a health center and a mobile van for homeless. And we have 2 school-based health centers as well. In Madison County, which is about 90 miles east of Memphis and Jackson, Tennessee, we have 1 health center that has a co-located pharmacy, and we also have a women's health that we just opened up around the corner from there. We actually have 2 clinics there now. And we are the only FQHC in Madison County. Our patients that we serve, we have about 60,000 medical patients, 10,000 dental, and 4,000 behavioral health. Medical, dental, behavioral health, and pharmacy. Our medical visits are about 150,000, and our pharmacies filled close to 160,000 prescriptions. That's our in-house pharmacies. There's a little bit of a glossary because I talk in acronyms. If you're medical, pharmacy talks in different acronyms than medical. So these are just some of the things I'll talk about. You hear me say CE and EO a lot. CE is covered entity. You all know what that is. EO is entity owned. So that covered entity owns the pharmacies. That's what that means. We all know HRSA. If you don't have pharmacies, you may not know OPACE. I'll talk about that as well. Office of Pharmacy Affairs, and that's OPA. And then OPACE is the information system. That's their website that they use. And then I will talk about third-party administrators or TPAs and third-party management. That's a little different. That is a third party coming in, manage your pharmacies. And then along with AWP, UAC, those are the pricing of medications. So history of 340B, I heard someone else did a 340B talk, so I'll kind of go through this a little bit. 340B was started in 1990. It was a Medicaid drug rebate program, so it was initially only for Medicaid. In 1992, it was expanded to safety net providers. When it was a Medicaid program, it was a rebate-based program. Medicaid solicited providers to give rebates based on the medications. But when it was expanded in 1992, it expanded to upfront discounts for safety net providers. So this means, now you can have that discount on the front end. You don't have to invest the money to buy it wholesale or AWP or WAC and then solicit a rebate, because we know that can take some time and that can tie up a lot of money. So they went for upfront pricing. When we had Affordable Care Act, that expanded it a little more. The discount got a little deeper. And now we have inflation reduction, which is changing it yet again. But that's a whole nother story. That's a whole nother presentation. So this is just to show you that 340B is constantly changing, but it is law. 340B is in the law. The reason it's 340B because it's in the Public Health Service Act. We all know 330. If you get public funding, you know 330. Well, the next section, 340. The Section B is where this expand the MDRP to safety net providers. The purpose of 340B, and I know 340B is a little daunting, but the purpose of 340B is to enable covered entities to stretch scarce federal resources as far as possible, reaching more eligible patients and provide more comprehensive services. So this is something we're all used to doing. We have to do more for more patients with less. But this is a way you can expand your less to be a little bit more, so you can do the more. 340B there's certain types of entities. It's not open to everybody. You have to be a covered entity. Covered entities for 340B are certain types of hospitals, and there are also non-hospital entities. And these are FQHCs, Ryan White clinics, STD clinics, homeless clinics, black lung, various types of clinics, and also FQHC lookalikes. If you receive federal funding as you are eligible, but as we know, lookalikes do not receive federal funding, so you are still eligible for 340B. How does it work? So if you decide that you want to have a pharmacy program, you go and register on OPACE. OPACE works in quarters, so you register one quarter, you're eligible the following quarter. And this is for most outpatient drugs. So what you do once you register that, then OPACE works with your manufacturer. Your wholesaler, to give you upfront pricing for 340B that next quarter. So then it's updated quarterly, and you have access to it to order it directly from your wholesaler. This only covers outpatient medications. It does not cover vaccines, and it does not cover medical supplies. However, there are ways for you to get additional discounts for things such as vaccines, because we all know vaccines are very, very expensive, but they're very, very vital as well. Every quarter, HRSA will then publish the 340B pricing, and they give that to the people who have access to it are covered entities, wholesalers, and manufacturers only. They do not publish it to insurance companies. It's not the insurance company's business, even though they find out in some way sometimes. But that is not who knows. It's the people who are involved. And you can also join, once you become 340B eligible, you can also join the Prime Vendor Program, the PVP, which gives you additional discounts and sometimes sub 340B pricing on things such as IUDs, which a lot of clinics use IUDs. You can get sub 340B pricing, which is even lower pricing on your clinic administered drugs additionally. It's a voluntary program. You don't have to join it. You can also get discounts on vaccines. The things that are not covered sometimes are also on the PVP. They help with your negotiations with your wholesalers. The one thing I hear all the time, especially from providers, is like, I feel a little weird that we're getting these cheap drugs and we're trying to make money off of them. Well, that is the whole purpose of the program. It is designed to give higher margins for covered entities on medications. This is a way for us to all work together to bring in extra revenue for the organization. This is why we have 340B. When we talk about savings, we talk about 340B savings. We always say savings. As you can see, it's the price minus the 340B price. That's the customary price. That's the margin. That's what's higher. So if it's normally a $100 drug and you get it for $20, you have an $80 savings. The way this works in pharmacy, you have contract pharmacy. And so your contract pharmacy savings is what the reimbursement is for that medication. And you have to subtract out TPA fees, dispensing fees, actual acquisition, which is the 340B price. And when you move on to entity-owned or your in-house pharmacies, you take out that middleman. They're literally the middleman. The TPA and dispensing fee are removed, and it's really just the reimbursement minus the acquisition costs. So this is why having an in-house pharmacy can almost always, a little bit more lucrative as far as savings for the covered entity. And yes, you can bill insurance. You can and you must, just as any covered entity. As you know, if a patient has a third party to pay for their insurance, to pay for their services, you have to bill their insurance. You have to utilize all resources. And you can have a sliding scale for your prescriptions. It doesn't have to be the same as your medical sliding bill. It can and is usually different. You can have different ways of applying your sliding. So you can have a cost plus or you can have a flat rate. It all depends on what you decide. And you do not, when you bill those insurances, you don't have to say, okay, I only paid this much. You don't have to give me as much. Your pharmacies are independent pharmacies. They get the same contract. Pharmacy, PBMs, I should have put that on my glossary. Pharmacy benefit manager are required. They cannot discriminate against covered entities. They cannot reimburse you at a lower rate. I put asterisks around that because insurance companies are always trying to. But for your commercially insured, they cannot discriminate against you. They reimburse you for that medication at the same rate as every other person with that contract. If they're paying everyone else $500 for that medication, it doesn't matter if you got it for $100 or $50. Or even a penny. It doesn't matter what you paid for it. They have to pay you for it. So when you have 340B, that acquisition cost is about on average, about 40 to 50% lower. So that difference is what you are saving. So it is designed to bring revenue into covered entities. I hear all the time, I feel bad. I feel like we shouldn't have. I feel like we're doing something wrong. You're not doing anything wrong. Having a pharmacy and billing insurance company and having that higher margin is the entire purpose of 340B. And I always say 340B is a way to include pharmaceutical companies and insurance companies in covering the costs for underserved. We already know the government pays for it. And we already know that we as individuals pay, we give to our patients all the time. But this is a way for the pharmaceutical companies and the insurance companies to do their part. The pharmaceutical companies have this discount. They've agreed to this discount. This is their way of providing back. The insurance companies have to pay us. There's really nothing off of their back, but this is where we get the revenue from the insurance company. So it is a way that we spread the cost. It's not just government. It should not only be on the government, but pharmaceutical manufacturers share in the cost. Now, 340B, if you listen to pharmaceutical manufacturers, they'll tell you, oh, it costs us so much money. 340B is about 5% of the prescriptions that they ship. 5%. And we all know pharmaceutical manufacturers are doing okay. It's just 5%. They would have you think that they're shipping out half their medications at 340B pricing. They are not. It's 5% of their revenue. When you have these savings, there's a lot of ways that you can give back to the patient. When you have a 340B, you are obligated to pass the savings on to the patient. So if you're buying it at a discount cost, you need to give it to the patient at a discounted cost. This means that sometimes you can give their insulin, which would normally be several $100s. Maybe you can give it to them a much lower price. Their inhalers might be a much lower price. Even if a patient is insured, you have to abide by the slide. A lot of times when you get on these contracts with PBMs, it does say you cannot waive or change copays. However, it says, unless required by law. That is the stipulation that allows covered entities to change copays for PBMs. That is always the biggest thing that you their copay is still high. I even brought this up to one of the biggest PBMs. I said, we have patients, we bill you, and it's $42. They can't afford it. It's $45, $47. And they literally gave me a piece of paper that says, if the patient's copay is higher than your slide, lower it to your slide. It is documented. And when you do recredentialing with another one, it says, do you change copays? You mark yes, and they ask why. You give them a statement saying, I'm a covered entity and I must abide by 330. They will take it every single time. It is required by law that we lower patients' copay. We cannot charge the patient higher than the slide, and we also are required to bill insurance. So this is how we get through it. This is what can really drive your patients. If they come to your in-house pharmacy, they now have access to the slide. Contract outside pharmacies, you can get a copay card. It's a little cumbersome, but if they go to the in-house pharmacy, you have access to that slide right then and there. And your pharmacies can set it up to change their copays based on slide. Does that make sense to everybody? Okay. So with those additional savings you get through 340, oh, go ahead. Yes, that payer that I talked to, it was because of their Medicare Part D. That is a very good question. I'm glad you asked that. Their Medicare has very good, they have high quality, Medicare is all about the quality. So I have meetings with them all the time. And they were talking about, this patient didn't pick up their Januvia. And I was like, but they did, but we didn't bill you and this is when I first started. I didn't know all of this. They did, but your copay was too high, so we had to put it on the slide. And they said, let me give this to you. And they gave it to me. They says, bill the insurance because we need you to bill and show that you're caring for this patient. Because a lot of times you have adherence rates for your pharmacy, your PBMs, you'll have adherence rates. And that's part of your quality program. And so we were falling behind. We're like, no, we are filling it. They're just not, the copay's too high. And they said, fill it, change the copay. So they know. So yes, that's a very good question because it's typically the Medicare. And also if the patients can't afford it, they also have access to additional help. That's a whole nother, do we have 2 hours? I could talk to you 2 hours on this. But yes, it applies to Medicare. It applies to commercial. Medicaid is I'll talk about that a little bit, but Medicaid, you don't necessarily need to change the copays, but patients can waive copays depending on your Medicaid. Everybody's state Medicaid is different. Consult your Medicaid provider. I don't want to say anything because I know California is completely different. Everybody's Medicaid. We're in Tennessee, but we don't have expanded Medicaid. Ours is different from a lot of other places. So consult your Medicaid. Medicaid loves 340B as well because it lowers their cost, because we bill Medicaid at cost. So Medicaid it's not a huge moneymaker, but you bill Medicaid at cost and they give you a higher reimbursement, like a dispensing fee, than typical dispensing pharmacies typically. So our Medicaid gives a much higher dispensing fee than they would like a Walgreens or something. They love it because it brings down their cost. You know, what they would normally pay $600 at a Walgreens, well, they're only paying like maybe $100 for us. They love 340B because they want to bring down the cost. But there's a whole thing about duplicate discounts that I'll get into later. But yes, you can create your own sliding scale. A lot of times, like I said, it's a cost plus. So whatever your cost is, you add a dispensing fee and then maybe round it up. Or you can say everything in this category is $5. Everything in this category. You just have to have a policy and have it written down what your sliding scale is. That's the most important. There's nothing standard. You can do what you want. Okay. With these savings, you have a lot of things you can do with it. You can add, of course, I put clinical pharmacy up top because I'm very, very partial to it. You can have clinical pharmacy. The margins you get can cover medication delivery. We all know transportation is, at least at our health center, transportation is our number one barrier. We're working on medication delivery because the margins can really cover the costs of medication delivery, and that keeps them more compliant. It improves their disease progression. It's great things that you can do with it. You can add social workers. Sometimes social workers, the time that they spend it doesn't equate to what they're actually doing, but having that social worker to help is vital, because sometimes, like I share an office with our behavioral health, so we're always talking about social workers and how she's like, you know, they can bill for this, but they spend 75% of their time doing these other things. And I was like, well, that's one thing that having 340B can cover. Patient transport services, getting into clinics, dietitians, optometry, physical therapy, those can bill on their own, but sometimes there's an upfront cost of having those services. So that can cover having that upfront cost, and then they can bill on their own. And you can also expand the scope to include specialized services. There's a whole slew of things. These are just examples. There's a lot of things you can do. I'm sure all of you can think of what you can do with additional revenue in your health center. So hopefully some of you are here, and I know one person is saying, how do we start a 340B program? You have to ask, there's 3 different types of pharmacies. Well, there's really 2 different types. There's contract and there's in-house. And then and within your in-house, you have entity owned and managed, and you have third party managed, entity owned, but still third party managed. So you have to think about, how do you want your pharmacies to look? What's your end goal? And sometimes maybe just contract pharmacy is good enough. If you have a lot of specialized services that require specialty pharmacy, maybe it's just a contract pharmacy. And maybe if you have a lot of generic medications, maybe contract isn't really that great, but I'm here to argue it probably is. But we'll go down that road. I'll be talking about these different types of pharmacies. And there's pros and cons to all of them. For contract pharmacy, has high margins. It's smaller, but it really is high margins. But based on what you really could be getting, you're not getting as much as you can. But you do have high margins on contract pharmacy. There's almost no overhead, except for the fees. You have the fees, but the restrictions are high. You cannot claim every prescription that goes out of your clinic. It's a very low rate, and I'll show you later but we capture a very low rate of our contract pharmacy prescriptions. Contract pharmacy has high restrictions, and they're always adding restrictions. Now, state laws, a lot of states are working to pass legislation to prevent that. But if you're not in a state that doesn't have it, the thing is, it's always changing. You might have it today, you might not have it tomorrow. Contract pharmacy is, in a way, the easiest, but it's also the most complex. I know. It's entity owned. That's where you own your own pharmacy, but you have somebody else managing it. Entity owned, third party managed is where you own your own pharmacy. It's in the 4 walls of your organization. You own the pharmacy, but you have a company coming in. They might have the employees. They manage it. A lot of the overhead they capture. Now, there's still overhead. You still have to buy the drugs. You do have to have the pay for the TPM. It's a little easier because you don't have to try to train your own staff. They usually come with their own staff, highly trained. Because it's entity owned, your restrictions are lower. And I put it a little bigger because there's a little bit of a gray area that they're really trying to attack it. But for the most part, there's not any restrictions on that. And then you have entity owned, where you manage your own you're the CE, the covered entity manages the whole thing. You have your own pharmacies. They're your people. You don't have anybody else coming in trying to take care of your patients. Those are the three main types. I'm in all of them. Well, I'm not in the middle. We have contract and we have entity owned. We have 6 entity owned pharmacies and we manage them. A little history on contract pharmacy. It was like I said, 340B was introduced in 1990. The covered entity is 92. Contract pharmacy was introduced in 1996. Initially, it was a 1-to-1 basis. You could find a pharmacy and say, hey, can you do this for us? And that was how it was. It was expanded to unlimited in 2010, and that is when the manufacturers really started getting upset, because that's when it really expanded to really bring in a lot of money to covered entity. That's the portion that's really under attack by pharma. One thing I cannot stress enough, it's very easy to say, I have a contract pharmacy, I have somebody handling it. That is not true. You, as a covered entity, have to assume all compliance with the program. You cannot trust that somebody else is going to do it. And I speak from experience. We have lots of TPAs. I have TPAs. I have 4 different TPAs. I had a TPA who unblocked restricted medications one time. Unblocked them by not our request. We got a new account manager. They unblocked it. And we captured ineligible prescriptions for 3 months. And when we went back and we said, hey, you guys did this. Why did you do this? They said, sorry. And we said, what are you going to do about it? They said, we're not going to do anything about it. We were required to file the disclosure and pay the money at whack back to that manufacturer. We did nothing, but the TPA is the one that made the mistake. We were on the hook for it. Please do not think if you have a contract pharmacy, someone else is handling it. They are not handling it. They didn't catch it. We caught it. They would have kept going on, and that could have cost millions upon millions at the end. So you have to be vigilant for your 340B program. Don't think that somebody else is doing it. We're just going to gather the money. You are not. You have to have somebody who is looking out for your covered entity. And it's not hard. I'm not saying that it's just going. You can have one person who is well trained or can even learn as you go through this how to overlook, but you have to have somebody in-house looking out for your covered entity, because without it, you're putting yourself at risk. And when you assume all compliance, that means you are saying you're going to have adequate oversight. That means you're going to make sure that what they're doing is not a loop, because they've got the money. Once the TPA made that mistake, they got their money. They kept their dispensing fees. They kept all of that. They didn't give any of that back to us. They kept it all. Do not think, TPAs, I'm not saying TPAs are bad people, but they are not looking out for you as a covered entity. You have to look out for yourself as a covered entity. However, the amount of revenue you can get can easily pay for someone to have the oversight of this program. Easily. And if you have, like when I started, I knew nothing about 340B. My 340B program manager, when she started, she knew nothing about 340B. We learned in over 4 years, she has become a solid expert. She knows probably 3 times what I know, but she knows it very well and she can manage it very well. She can catch things in an instant. She audits everything. It's possible. One person can do it, but you have to have adequate oversight. You have to avoid diversions. The biggest thing, duplicate discounts. That's when you buy a 340 medication, you dispense it to a Medicaid program, a participant, and you don't tell Medicaid. Medicaid then goes to that manufacturer and says, hey, I need a rebate on this, because the Medicaid discount rebate program is still effective. So when a prescription is dispensed out in retail pharmacy, we don't capture those for 340B. We do what's called carve out. We don't capture any of those. We let Medicaid then go and get the rebate for it. That we can't say, hey, we're capturing at 340B and Medicaid's also going for the discount. You can't do that. That's called duplicate discount. That is one thing that will get your program shut down in an instant. You have to make sure they're not captured, because TPAs have done that as well. They have captured a TennCare. I'm in Tennessee. They have captured TennCare medications. And then TennCare goes out and gets the rebate. We have to then have them reverse it. So you have to be on top of it. You have to be on top of it. If you catch it within like 30 days, they'll reverse the claim typically. Then you're all good. But if it's a year later, they can't reverse a claim. You've got to pay it back. That's why you have to have somebody on top of it. But there's enough revenue in there that you can have that person to make sure you have all 4 of these things. These are the 4 things: oversight, diversion, duplicate discount, and audible records. If HRSA comes in, even if you have just a contract pharmacy, you still have 340. You're still eligible for 340B audits by HRSA. HRSA will come in and audit your 340B program. You have to have auditable records. You have to show that you're having the oversight. Now, TPAs will say, "Oh, we'll keep that for you. Don't worry about it." Worry about it. Still have it. I cannot stress it enough. You need to have someone in-house looking over this for you. When you want to have a contract pharmacy, you need to consider what type of medications are you frequently prescribing, what pharmacy are your patients using. You can get all that information out of your EHR. What pharmacy is your number one pharmacy that you're sending to? And I can tell you right now, if it's a Walgreens, Walgreens is its own TPA. You just go to Walgreens and say, "Hey, I'm interested in starting 340B contract." I can guarantee you they will jump on it. They're a pretty good program. They're very thorough. They're very good. They're our biggest TPA. Well, you just kind of have to look, and then you can really structure it how you want. If you are brand new to it, start with one pharmacy. Start with that pharmacy and really grow it from there. If you have one person looking it over, they can really study your program and say, "We need to expand it." Because when I got here at Christ Community, we only had Walgreens. We then expanded to 3 other, and we've expanded it more and more. And so now to where we are. So, and remember, for contract pharmacy, this is where manufacturer restrictions really are. So, like I said, it began in mid-2020. I started in 2021, so I was at the very beginning of it. And then Eli Lilly was the first. And then monthly, every manufacturer just started adding restrictions to the point now where I think just about everybody has a restriction. And it can vary. Some of them only limited to hospital pharmacies. Hospital pharmacies and 340B is a whole nother talk I can have as well. It's a whole, they've complicated this for everyone. If you have a in-house pharmacy, they can say, "Okay, you're limited to just one contract pharmacy," or they can say, "You can have no contract pharmacies." It's very different. And then there's also this thing called 340B ESP, which is a clearinghouse where you can submit your claims and show that, you're billing, and they can verify, and they'll say, "Okay, you're good. We'll send you your money for it." It's a complicated extra step, and 340B ESP is... We just started doing ESP because of restrictions. So it's a very complicated, and they have these requirements, and it's not very transparent, but it's a lot of work, but it's possible. I'll just put that there. So that was contract pharmacies. So let's move on to in-house pharmacies. Now, if you want to start with a third-party managed, you have to consider, do you have the space? What kind of pharmacy you want? Open door, closed door. Open door is where anyone can come in regardless of who they see and fill a prescription. Closed door is when you service only your patients. I will say closed door does provide some obstacles for third party, but have your contracting person really read the contract, because a lot of the times it's just in the wording. Can anyone come into our pharmacies to fill? Sure, if they see one of our providers. Anyone can walk into our clinic and fill. I mean, our clinic's open to everybody. Then you have to decide, you want virtual or physical inventory. That's when you have a separate 340B and a separate non-340B. That's a physical inventory. Or if you mesh them together, you buy everything at WAC or AWP or whatever your contracted wholesale prices, and then you reimburse yourself based on 340B. That's a little complicated, very complicated. So you have to decide. That's why most entities decide to have only 340 because it's a lot easier. Are you okay with employees who are not your employees working in your clinics? If you have a third party managing it, they own the employees. That means if you have certain standards, you want your employees to be a certain... They don't have to abide by it. This is a publicly traded company. They have to hire whoever is eligible for the job. So being a faith-based, sometimes that means you might get a non-Christian as your pharmacist. Now, usually that's not the case. Most third party will allow you to kind of interview and really feel out, but some of them don't. You just get who they give you. You have to be okay with that. Do they offer delivery, or do you want to do walk-in only? Do you want to do OTCs? OTCs are not covered under 340. Well, you get a discount. It's complicated. OTCs are different. Do you want to have that? Do you want to have a whole section for 340 for OTCs, or do you just want to do prescription? And what's your long-term plan? Do you want to keep them, or do you want them to eventually be transitioned to be managed in-house? These are some of the pros and cons. Low overhead. You don't have to get your own people. It's very quick. A lot of times they come in, they know how to start a pharmacy Like they do it all the time. They can get your pharmacy up and going in 6 months. Whereas if you were to do it yourself, you'd have to source the right people. You have to make sure somebody knows how to do this. That might take a little bit longer. These programs are highly proficient. They know how to do invoicing. They know how to do contracting. They know how to do all these things that might take a little bit more for a covered entity. They can help you track compliance, and they perform and assist with audits. However, there is heavy fees for it. And not only will they charge you, it's a contract employee. Usually that's twice the price of the regular employee, plus the overhead. So there's a lot of money that's involved in it. It can sometimes give you a false sense of security because you're like, hey, it's an in-house. They're doing it all for us. Don't trust anybody with your 340B program. Trust yourself, trust your employees. You still have somebody in-house looking it over. And the employees they're employees of the entity, not of the TPA, not the entity. So just be aware, you don't have the ability to go and say, hey, I need you all to function this way. That's not how that works. They're the employees. Same considerations for if you have entity managed, this is when the covered entity manages and owns their own pharmacy. Same considerations, open door, closed door, space. Additionally, you have, can you hire the knowledgeable staff? If you haven't figured this out, 340B is a little complicated. You have to have knowledgeable staff. You have to have knowledgeable staff. If you're going to open a pharmacy, they have to know day one how to do this. That can be sometimes a hurdle. FQHCs we're not that common. So being familiar with the 340B space is not entirely common. Pros and cons, much lower cost for patients. You can offer that discount, and same thing with the entity, and you can still own the discount. You have higher margins that without the TPA cutting into it. You control your employees. You control the direction and breadth of your program, and there are no manufacturer restrictions. The biggest con and biggest hurdle is the overhead. Constructing a pharmacy, getting the staff, getting ready for that, finding a 340B savvy team, and a lower cost, a longer wait to cost and become profitable. And you still need to do audits no matter what. You're still going to need to do audits. So as I said, the compliance, you have duplicate discounts. I'll just let you all read that. But you have duplicate discounts you have to monitor. You must pass the savings on to the patient. That doesn't mean all the savings, you're handing the patients the money. It has to be given back to the patient in some form. That can be in additional services. That can be in a happier staff because you're paying them a living wage. That it is a way you can give back to the patients. If you can retain staff, and you can give higher quality, that's still giving back to the patient. Now, this is not, we made $6 million, let the executive team split that up and put it in our pockets. That's not giving back to that. I'm not saying you can't give bonuses, but I'm saying when you get these profits, it's not let's all profit. Put it back into the covered entity. What are we doing? And yes, you can. Like if the staff you're not paying your staff well, then maybe it's increasing their pay. They're easier to keep. You're going to retain. And we all know it costs more to hire new staff than it is to keep the staff. That's giving back to the patient. Because if they can come back and see the same provider, see the same nurse, that's giving back to the patient. That's not completely out of the question. But that also, like I said, the sliding scale is another way of giving back. You create your own. It can be a flat rate. It can be a cost plus, either way. You still have to have the same eligibility screening as you do for medical, but we use the same process. Whatever they qualify for medical, same for pharmacy. And you still have to have audits to show all of this. I'll go really quickly on this. Roadmap to contract pharmacy. We have to determine all of these. You still have to have an executive buy-in. Having the executives understand and know that this is a benefit is the number one thing. You have to know that 340B is a crucial part of our organization. If you have in-house managed contract pharmacy, you have to have an experienced 340 they're called to lead. This is for contract pharmacies. You still have to have somebody in-house to oversee it. You have to find a TPA that aligns with you. You have to find a contract service agreement that has comprehensive services. This includes ship to, bill to agreements with your wholesaler. It's very complicated, but the wholesalers know how to do it. And once you have a TPA, they can do it. Create an audit plan and grow, learn, and network. That's why things such as there's a lot of conferences. There's FQHC conferences. There's 340B conferences. There's a website, a chat group we call NoddlePod that it's all pharmacists, and we're all on there. We all have problems. We're always sharing what we're doing. So a lot of times we see, hey, they're doing this. Oh, I think that would be great here. It's such a great resource. NoddlePod is great. I'll keep going because we're running out of time. So anyway, let's talk about, so if you want to do this, how do you choose? You don't have to choose. You can start with contract pharmacy. Start a contract pharmacy. I would say, like I said, have somebody in-house to help oversee it. They can be a complete 340B novice because you have the TPA there to help them learn and grow. So start with contract pharmacies. Find a single TPA, whoever you use the most, use them. That person, work with them to do audits, to have oversight, and then reserve part of those funds. Are you getting $100,000 a month from it? Okay, well, let's reserve $10,000 a month because we know that we eventually want to have our own pharmacy. You eventually just grab a little bit from those savings, put those savings back into the covered entity, and then eventually you can grow to the next step. The question was, can MAs oversee the auditing of this program? Absolutely. Anybody can do it. MA, nursing, somebody who doesn't even have a pharmacy or medical experience, anybody can do it. Especially since you're starting at contract, this is the time to get somebody in to start to learn it. They can have any qualification. This is the beauty if you're starting with contract pharmacy. You don't have to have a fully knowledgeable person. Now, it is helpful to have somebody with medication knowledge so that they can see something and know, like, oh, that's probably not right, or that shouldn't be captured, or, that is knowledgeable. But this is not a clinical, like, they're not making clinical decisions. They can just identify, hey, this one, if we're using this one, they can make recommendations for your in-house pharmacy or for your in-house clinic administered drugs. Hey, this is in the same class. We can get this at this price. Maybe we should shift to those kind of things. But for the oversight, absolutely, anyone can do it. Okay, so for contract, like I said, when you start don't have the overhead. You have somebody in-house learning and growing with the program, and then you put some money aside, and then you say, okay, we want to do an in-house pharmacy. And maybe you start with a TPA because now, like, maybe say you have an MA over your contract, they can't really help with the in-house pharmacy. So now you've got to grow your team. And there are third-party managers who have an agreement. A lot of them aren't into long-term pharmacy management. They will come in, set it up, and say, you can make an agreement. Hey, in 3 years, we want you to turn it over to us. And they're like, great, we don't want to be here more than 3 years. There are some that are in long-term and say, hey, we always want to do this. That's fine too. But if you know that you eventually want to become entity-owned, then you find a third-party manager that says, hey, we'll come in, we'll hire your people, you have a say in it, and then as it's going, of course, they're going to take their cut on top. But at the end of the agreement, they hand you the keys and say, this is your pharmacy. Now you have an experienced, trained staff who know how to do this. And now you've moved on to entity owned and managed. That's kind of how you can progress. So it's not so daunting. Like, I know a lot of people like, oh, an in-house pharmacy, yes, you get lots of revenue from it. But that doesn't mean you can't also get it from contract pharmacy. And if anything, our contract pharmacy is actually higher than our in-house pharmacies. So this is the facts about my pharmacies. I have about 45 employees. Like, I have 6 pharmacies, 45 employees. Our providers sent 180,000 prescriptions last year. So we're large. We're a little big. So if you don't do 180,000, it's okay. But the total of the percent of those prescriptions sent to our in-house pharmacies was about 49%. That's actually very high. This has been years of working up to this. We started out at 26%. So 30 to 40% is a very good capture rate for in-house pharmacies. If you're not at that level, then you will work up there. But this has been a work to get up to 50%. So then from those 89,000 prescriptions sent by our providers to our in-house pharmacies, our pharmacies with refills, because you have to count refills, we filled almost 160,000 refills. That means if we extrapolate, that's about, for every prescription, about 75% of them also got a refill. That's how we kind of figure that. If you figure that out in the outside pharmacy, that means that's probably about 160 to 165 prescriptions filled and refilled in the outside pharmacies. Of those 163,000 prescriptions, we captured 24,000. That's it. That's contract pharmacy. We captured 15% of the prescriptions filled at outside pharmacies. 15%. And I have 4 TPAs. I have just about every pharmacy covered, except for, I think we have maybe one independent that we have about 2,000 prescriptions sent to. Captured means those are the prescriptions that were, the question was, can I clarify what I mean by captured prescriptions? That means prescriptions that were filled at an outside pharmacy and we were able to claim that CB savings back to the entity. That's what we talk about captured. Sorry. See, I told you I talk in a different language. When you capture the in-house pharmacies are 100% capture. You recapture all those. You can get savings off of every single one of those. But for outside pharmacies, about 163,000 fills of those prescriptions. 163,000. Only 24 of those counted for our restrictions. Restrictions. Eli Lilly has an all contract pharmacy restriction. Novo Nordisk. These are manufacturers of insulins. Think of what some of your biggest if you're in primary care, probably insulin is one of your biggest ones. Boehringer and BI, we call them, they make Jardiance. Jardiance is one of your biggest. Restricted. Merck has restrictions. Restricted. So if you look at your top medications, are that probably a good 75% of them are restricted and you can't capture them. That's why contract pharmacy. Now, I'm not saying contract pharmacy is not good, because it's good. Because as you see, and our revenue down here, our in-house pharmacy, because in-house is very heavy on self-pay. Your in-house will always be heavy self-pay, because if you self-pay, they're not going to get their insulin for under $25 at an outside pharmacy. And even if they do, they're not capturing it, because self-pay is always, your in-house is always going to be heavy self-pay. Our in-house on average is about $50 per prescription. But in contract pharmacy, it concentrates. There's a lot of factors going contract pharmacy. We have winners only, because that's the other thing as to why we don't capture so much. We have winners only. That means if it doesn't bring a profit and bring money back to the NC, we don't capture it. That means a lot of generics are not winners, because you have to have the reimbursement, the cost of the medication, and then the TPA fees, and then the dispensing fee. They will throw fees on top of fees on top of fees. I remember one time one of our TPAs said to us, "Hey, your program's growing. You've increased by 45%. And we said, "Yeah, but our captured revenue has not increased." Their fees increased so much that even though we were capturing more prescriptions and it was getting bigger and bigger and bigger, we weren't seeing the revenue from it, because their fees will go up. And that's the other reason you need to have somebody in-house to check those fees and say, "Hey, is this fair?" Because remember, the only ones that don't have competition is Walgreens. Just about everybody else has competition. Walgreens doesn't give their information to anybody, so you have to use Walgreens. But if you're using PharmaForce and their prices go up, well, go over here and look at Nuvum. Go over here and look at, there's others that may do the same manufacturers. There's well partnered. Like, just look and see, and then you can start to shop around. My 340B program manager is always shopping around. She's always, and when she finds it, she can go back and say, "Hey, they're offering me." I mean, don't be afraid to say, "I'm leaving because your prices are too high." And if they make errors and we threaten to leave, they cut our prices by 60%. So you have to be able, if I didn't have her always looking at that, we would be paying those high fees, cutting into our prices, because we wouldn't have noticed it, because we were still getting the same amount. But they were getting more and more money. We weren't getting more and more money. That's where I say you have to be the owner of your 340B program. But when you have a winners only program, that's why contract pharmacy is much higher, because that you have a specialty, like you're very concentrated in specialty. But when you have in-house pharmacy, you can bring specialty in-house. And specialty is the way that pharmacy is going. Specialty medications is 50% of the medications in the pipeline. Actually, probably more than 50% now. All the new medications coming out are going to be specialty. That's a whole nother talk. I know specialty is complicated. I just want you to know that contract pharmacies can be useful, and they're a great way to get into the 340B market. So I just want you to know that you can have it. Great way to start. I'm not against contract pharmacy. I have contract pharmacy. Contract pharmacy is our biggest contributor, but you have to manage it correctly. Okay. That is after contract. That is what is deposited into our account, but that is not after the cost of the medication. Our actual growth, I'm so glad you have, like, that's how I talk. I can give you gross profit numbers. Our gross profit is, I can tell you that later. I don't have it in my head, but I have it on here. But the cost, of course, is higher because they're higher cost medications, but we still get plenty. There's still great margins on there, because there's some specialty medications that can be really, really low and you get a really big return. One thing, like we all, especially in STD clinics and things like that, Hep C is a big one. But Hep C, you cannot claim on contract pharmacy. It's restricted. The question was about steering patients to specific pharmacies based on your TPA or your agreement. You cannot steer patients. If patients ask, you can, give them suggestions, but the patient still has the right to say they can go to any pharmacy. That's why I say look at what pharmacy is your most frequently used, because that's a popular one. And you can say, hey, and a lot of times the insurance companies will steer patients themselves, especially if they'll steer them to one specific pharmacy or very limited network. That's why it's good to have a breadth of TPAs and cover all of your pharmacies as much as possible so that you can capture as much, and it still gives the patient the choice. However, there are definite advantages. Like you can't say, go to our in-house pharmacy. That's the only place I can send it. But if you know that it's usually a prescription that has a prior authorization associated with it, a lot of times, because I have clinical pharmacists, and they 75% of their prescriptions to our pharmacies because they say, we know what the price is because they have access to our pharmacy system because they're pharmacists. We can give them access to that. And they still work in the pharmacy. So they know, okay, I know that if we do this one in this class, even if it has a PA, our pharmacies can still dispense it on the slide. And then we have a team behind the scenes that works on the PA after the fact. Then that way the patient still gets the medication. They're not waiting, unless it's a high cost medication. If it's something that's on the slide, you can work on it behind the scenes. And sometimes, like one of the biggest things is some insurances prefer Basaglar. Well, that's going to be more expensive than like Lantus. They send Lantus. We try to get it covered. It doesn't cover. We'll stick you on Lantus because even if we do get Basaglar covered, after the fact, they can go in and say, what's your copay on Basaglar? It's $50. We're not going to use that one. We're going to stick you with Lantus. There's a lot of things you can do behind the scenes to bring that additional revenue in. Like if you know that this one is probably going to be covered, they just want some. Our clinical pharmacists and a lot of our providers know, hey, go to our in-house pharmacy. They can work on it. Our PA team prioritizes our prescriptions because we know they've already gotten that medication. They will work on every morning. They look to see what ones were rejected yesterday, and they work on those first to get those through, and then they work on outside. You can sell the advantages of the in-house pharmacy, but the patient still has the right to say, no, I'm still going to go to that one. That's fine. You cannot tell them they can't go. But that's still, if you have a very wide contract pharmacy net, you can still get it elsewhere. Good question. Any other questions? There is not. You can try to get a network with them. That's really a contracting issue. And, with Humana, they like to take their ball and go somewhere else. Like Humana is very difficult sometimes. But no, there's not a way around that. Humana does have, Interwell Pharmacy does work with TPAs, and that's their mail order. You can still capture some of those. Yeah. So go ahead. I'll try to repeat the question. Sorry. So his question was about free and charitable clinics benefiting from PHARM.D. If they are not a lookalike, is very unlikely. So they would have to work with the free partners, such as Dispensary of Hope, World Relief, all of those. That would be the most likely. We also use Dispensary of Hope in one of our pharmacies as well. So we do have access to the free as well. But unfortunately, it's either get the funding or be a lookalike. Unfortunately, there's not a whole lot. I cannot recommend anybody, but I can give you some experiences. Here's an example, some contract pharmacy administrators. I will tell you, we use Nuvum, we use Walgreens, we use WellPartner, and we use another one called CloudMed. That's for referral programs. That's a far more complex. I didn't even put it up there. PharmaForce is another really good one. Survey, here, some people use those as well that I hear of on Nanopod. And to be honest, that's the best place. You can say, what does everybody use? And you'll get a bunch of answers, and and a lot of times they'll say, what are you looking for? Like, it's really dependent. But we're also very helpful. Like, here's our structure, and somebody's going to be out there say, we are very similar. We use this, and here's why. The conferences, there's the BB conference. There's a grantees conference that I think is probably better. It's smaller. It's in these kind of random cities. Like I think this year it's Kansas City, and they're not going to be in like the Orlandos, like the big conference centers. They're going to be in smaller ones, but they are very, very good. You will meet nothing but covered entities who are going through the same thing, and you can get great contacts. It's all about contacts. It's all about the networking. I would say the 40B grantees, and I'm not endorsing it, but the 340B grantees is a great one just because it's smaller, it's more intimate, you can get a lot more out of it. Sometimes these 340B conferences, the NAC conferences, are huge. 340B is a little bit of an afterthought sometimes because there's so, like when you have these NAC, there's so much that goes on in these community health centers. 340B shouldn't be an afterthought. These grantees, if you don't, like, so we started specialty pharmacy and I went to, the National Association of Specialty Pharmacy conference called NASP for the first time. And I was like, okay, I'll go see. That's where I realized I was in over my head. I was like, I don't know. And I found another community health center. It was in Virginia. It's not a faith-based. It's called Central Virginia Community Health Center, CVCHC. And there's a pharmacist there, and he literally directed me in the right direction, and is how I got there. You have to network. We've all been in this same boat. All of us who have been in this, I'm overwhelmed with all of this. I have one more question. The startup cost of a pharmacy. So he wants to know what the startup cost of a pharmacy is. My answer is it depends. Depending on your space, you probably need at least about 500 square feet. Now, we did start in a closet, literally our pharmacy. We have seen pharmacies start in closet. To outfit it, to get it approved, licensing alone is a couple $1,000s. To get shelving and workstations, a few $1,000s. I would say when the last one we opened, it was a little under $100,000, but that was like 5 years ago. That was before all of the aluminum and all the tariffs. So I don't know. This, depending on the space, just the pharmacy licensing, the workstations, all of that inventory, right around $100,000. Then you have staffing. Assists are $200,000 anyway. No, I'm just kidding. Somewhere between 100 and 150,000, depending on your location. And then technicians are anywhere between $15 and $20 an hour. So that's about $200,000 a year. And staffing, you're looking at $250,000 just to start one. So that's why if you have somebody else that can, if you start with contract, know that you're looking to, let's get to $500,000, and then that you'd be comfortable, because right away, because you still have to get software alone, $100,000 a year. You have to get, there's still some overhead, but that you have a little bit of a cushion to get to the point where you can become profitable. The pharmacy that we just opened in 2022 started out, we were doing 11 prescriptions a day when we were chugging along. It's now my second busiest pharmacy 2.5 years later. They do all of our Vivitrol. Now, that's the one becoming specialty. They do a lot of our Hep C, a lot of our Vivitrol. They are bringing in the money. So it doesn't take long, but you still have to be able to absorb that for a year or two, on the high end 3 years. But it also depends on the type of medications you prescribe. One other thing, these are the people who, the consulting, these are some of the ones that I know of. The in-house pharmacy partners, that was the Central Virginia. He runs that. Cardinal Health is one that I know for certain is they will come in, staff your pharmacies, and hand it back over. They are not interested in long-term pharmacy management, but they do want to help you. They have Cardinal Health. If you have Cardinal as your supplier, they have a whole community health center program. They're very good partners. And to be compliance, that is run by all health center pharmacy people. They're very good. They can help you audit. They have roadmaps. They can help you consult. They're great. I'm not recommending, but I know that know people who have used them. Thank you, everybody.